Hello, everyone. Welcome. We'll give everyone just a couple more minutes to filter in here before we get started. All right, so we're going to go ahead and get started. Hi, everyone. Welcome to today's webinar. Today, we're going to be discussing the topic of Put a Ring on It, the secret to effective provider engagement. Today, you're going to be hearing from the awesome Dawn Carter with Centauri Health Solutions. Before I turn it over to Dawn, we are just going to go over a few housekeeping items. So some helpful tips. Please note that if you do have any questions, these will all be answered at the end. Any question that is not answered or gotten to will be answered directly after the webinar, so no need to worry. Any questions that you do have, we do ask that you drop them down in the little Q&A panel at the bottom of your screen or in the chat feature as well. And then you will be receiving a copy of the presentation as well as a recording of the presentation tomorrow from Rise itself. So without further ado, I'm going to turn it over to Dawn to get us started.
Good afternoon, everyone, and thank you for joining me today for what I promise is going to be an entertaining and enlightening session. And in keeping with our Put a Ring on It title, I thought we would just get things kicked off with Queen Bey herself. And she will remind us here of our webinar objectives, which are over here to the left, learning how to develop and implement effective non-clinical documentation improvement strategies to complement your clinical documentation improvement strategies. Second, to discover how to overcome barriers to effective provider engagement and enablement. And last but not least, understand the resources and tools you need to inform your enablement strategies as the foundation of a robust clinical and non-clinical documentation improvement program for risk adjustment. So all of that to say, we're going to take a look at these strategies just kind of, holistically. So we're not going to do a lot of deep diving because I want there to be something for everyone here. And certainly if there's anything you want to know more about, I encourage you definitely to reach out afterwards, and I would be happy to chat with you about this because, as you can probably tell, I'm very enthusiastic about CDI. So let's kick things off with a polling question. So here we go. Are provider engagement and enablement the same thing? A, yes. B, no. C, are we talking about marrying the providers here? Or D, what's love got to do with it? So pop your answers into the poll. We'll give you a little bit of time to answer the questions, and then Bailey's going to pop the results up on the screen and see what everybody thinks. And for extra effect, we've got our of course, the divine Tina Turner over here. We had Beyonce, we've got Tina Turner. Things are getting kicked off with our theme pretty nicely. All right, let's see what everybody said. We have 6% of you said yes, 91% of you said no, and good job. That is the correct answer. And we, of course, are going to talk throughout this webinar how they are not the same thing. Luckily, not anybody said, are we talking about marrying the providers here? Because obviously not. And what's love got to do with it? True enough. So let's get started with our journey down this path today. All right. So many of you out there might not be old enough to remember the person who is famous for using this term, the billions upon billions, to speak about the number of stars in the galaxy. And it was Carl Sagan. And a fun fact about Carl Sagan, when my father was an undergraduate at Cornell University, he had to take an elective, and he chose astronomy, and Carl Sagan was his professor. So fun fact. So let's take a look at some of the top of mind issues that speak to the importance of clinical documentation improvement, both and non-clinical documentation improvement, and provider enablement, so that you don't cost your organization, or no one costs your organization, billions upon billions of dollars. So first, top of mind is the V24 to V28 transition, which is well underway, actually. And of course, the overall estimated cost to MAOs is somewhere around $7.62 billion. And I'm sure a lot of you out there, especially those of you who are coders and auditors, are well aware of the differences in terms of what ICD-10 diagnoses map to HCCs. We, of course, have a reduction. We have 7,770 from 9,797, mapping to actually more HCCs. And we had 209 total ICD-10 codes added and ICD-10 codes removed at a number of 2,236. And I actually have a whole presentation and slide deck that kind of does a recap of this transition. And if anybody's interested in that, definitely reach out, because I do. A lot of people have done a lot of great pieces out there in the industry. And I also have a slide deck that discusses this transition and what you can do to get ready. Second, we hear a lot about targeted RADV. And in this space, you want to make sure that you've done your analysis based on the prevalence of your risk against the 7 to HCCs that are targeted in these audits. And actually, CMS or the OIG actually provided a toolkit to help plans be ready for these audits. And it's not if you get one, it's when. And so the extrapolated net overpayment for the 30 plus plans that have been audited so far is $463 million and counting, since they are adding to this list of health plans as they do these audits. The third thing is capturing social determinants of health data, and this is for health equity initiatives. And you want to make sure that you've done your analysis of how well these are already being captured in your claims data, and start to socialize screening and capture with the provider base and staff. And we'll talk a little bit later about who can capture these and what you might want to think about in terms of their capture. But it's something to think about, because eventually risk models are going to include this data for the purposes of risk adjustment. And then last but not least, this has been getting a lot of airtime very recently, denials management and prior authorization. Now, CMS is very interested in making sure that MAOs are providing the same care as fee-for-service, and is concerned that managed care denials are overly restricting care, and these particularly denials for prior authorization. And there was recent big news with the issuance of a rule which will require health plans to quickly make changes to comply. And you want to make sure that you've done your analysis of your risk and that you're proactively working with providers as part of an overall formal denials management strategy if you don't already have one. All right. So this enablement maturity model is actually something I developed because I saw something similar that another CDI professional had been working with, and I really, really liked it. And I like, oh, this would be a really good thing to, to marry with, what I see as our maturity model. And so I know that this slide is really busy and has a lot on it, and I promise you'll see it again. But I wanted to set the stage for our discussion with a good graphical representation of a robust program as a maturity model. So over on the left-hand side, if you're newer to risk, how you might want to start thinking about maturing provider enablement. And then if you're experienced, all the way over to the right, some of the things you want to be thinking about, which is moving more into more robust reporting. And this means you can start small. And because no good marriage, we're talking about engagement, put a ring on it. No marriage was made in a day. And also, you cannot monitor what you don't measure. So we'll be talking about how you ensure that you can be successful by measuring. And we'll examine each of these areas during our time together today. So before we go into discussing each stage of our maturity model, we need to define some terms. I promise this is the only math you will see in the webinar. So we have a definition of engagement, which is the act of being involved with something and encouraging people to be interested in something. We want our staff and we want our providers to be interested and engaged so that we can affect change. Enablement is the act of giving the authority or means to do something. And so that's our math, our bonus definition. Engagement plus enablement equals empowerment. And that's the process of becoming stronger and more confident. And so the message here is to effectively enable providers, you must engage them in the right way at the right time. Non-clinical CDI focused on data integrity informs and enables effective CDI strategies. So I'm sure everybody remembers, back when we were middle school, high school, when we would write in people's yearbooks, too good to be forgotten. So we've got two goods that we're focusing on today. Good documentation, of course, is the first. And most of us who are involved in CDI, or even if we're not, if we're just in risk adjustment or equality, any area, we know that good documentation improves communication. It increases the recognition of comorbid conditions that are responsible for treatment. It validates that care was provided for audit proofing and denials management. And it shows compliance with quality and safety guidelines. And these are things that you likely already know. And our second good is a good program. And first, a good program must demonstrate to providers the effects of documentation quality in terms of clinical and non-clinical, which is operational and financial value. And we're going to talk a lot about that today, how we do that. And then second, risk and quality outcomes must not be the sole indicator of engagement, but should be used as a starting point into how providers are being engaged and enabled. And I provided a couple of examples here that kind of illustrate this. And so the first is related to morbidly obese patients. They often require extra care as a comorbid condition, and hospital reimbursement, as well as risk-adjusted reimbursement for these additional costs, depends upon provider documentation. So we can't just assume, we all know, a lot of us out there who are coders understand, how things are monitored, evaluated, assessed, or treated, and when we can pick that up as the comorbid condition. Second example is that a provider will often document an unspecified code, such as CHF nonspecific, because it makes no difference to them from a claim payment perspective. They're still going to get paid for those services that they provided. However, a hospital and a Medicare Advantage organization, for example, need acute systolic CHF to accurately capture the costs of caring for this patient. So that makes a difference. And then in either case, is it really fair for providers to not do their part? And the hospital or MAO suffers financially. And then as a result of that, the quality of patient care is affected. And we can show by, like I said, measuring and monitoring when this is the case and where improvements can be made. So as we make our way across the continuum that you saw a few slides ago, we are going to bypass education for now and jump right into workflow. So EMR integration and pre and post visit CDI workflow is a whole topic that could have a webinar unto itself. But I just wanted to say just a few generic things just to whet the appetite and things that you can think about as you're setting up your programs or wanting to refine them. And pre-visit is where we are evaluating gaps. We're looking at medication lists and updating them, hospitalization records that might have come in, emergency department visits. We're updating problem lists, screening and documenting for social determinants of health. And then we might want to consider even a specific EMR template for the annual wellness visit versus a physical. So I wanted to say some special notes here about who can document social determinants of health, because this is important. Because remember, CMS is going to be incorporating this into risk models. So this is an area that's top of mind. Now, it doesn't have to be only a physician, nurse practitioner, or equivalent to document these, but it can be others. It can be people like social workers, community health workers, case managers, patient navigators, nurses, medical assistants, which is why up here in pre-visit, I have medical assistants, certified coders, others. Now, they can be collected through health risk assessments. There's formal screening tools out there, can be person-to-provider interaction, and of course, individual self-reporting when the patient themselves reports them. So those are some notes about SDOH. And I want to say a few notes here about the annual wellness visit. Now, annual wellness visits, of course, are one of those tools that Medicare, and providers use to kind of gain an understanding of their membership and what types of chronic illnesses they might have or other needs. And providers that have higher annual wellness visits usually capture those HCCs and quality more timely and accurately, so that gap closure is occurring more frequently. Now, the annual wellness visit is a hands-off visit type. So you think of it as an opportunity to bring the patient's medical record current for the year. Now, many people confuse an annual wellness visit with a physical. A trick to remember is AWV is hands-off, physical, hands-on. You also want to be sure that you wait 365 days between annual wellness visits. And this helps to simplify the eligibility requirements between all of your contracts, and it also ensures enough time has passed between the last one and the present one. Now, when you have a patient coming in for an AWV and the office bills an additional level of service like a 99213, the patient will likely be asked for a copay. Now, this may catch your patients off guard since they are told this is a quote unquote free appointment. So you need to be very clear on when it is appropriate to bill a regular E&M code. Now, having an AWV template built into your EHR or your EMR is critical. This will make documentation much easier for your entire team, and it will also help to ensure all of the key points are reviewed. And of course, they out in Medicare and their outreach and education site, they do have a lot of what I just talked about in terms of the requirements for the AWV. So check that out if you have any questions. Now, you might be looking at this slide, especially when we look like during the visit, we have providers and other clinical staff that need to also review and update problem lists, especially if copying and pasting is occurring. And again, that could be a whole webinar also. Ensuring that all gaps and chronic conditions are reviewed and documented, meet reviews, what I call it, and ensuring that labs and other test reviews are reviewed and documented. So that's during the visit. And then post-visit, you'll want to have your coding staff making sure that they're reviewing the codes that were suspected or open gaps, as we often call them. Were they captured, and then were they dropped to claims? Because we will talk later on about things that happen with that dropping to claims process that can affect risk and quality. And they are also providing coding and documentation feedback. We're going to look at how we evaluate for that. And then, of course, querying the provider. And you'll see querying the provider kind of happening at every step of the continuum because it's very important. And it's actually a skill. So we'll talk a little bit more about that later also. So as I said, you might be looking at this slide saying, oh, I need an army of people to do all these things. Wow. Most often, I have seen the upskilling of existing staff to handle these. And if you are using the right tools to quickly identify your care gaps pre and post visit, it'll be much more efficient. And I've seen out there in the industry some really innovative things that payers and other entities are doing to upskill their staff and deploy them a little like working smarter and not harder, basically. And it's pretty amazing. Now, I get asked a lot about where AI fits into all of this. And my best answer to that is what a physician at a recent RISE panel said. I imagine a lot of you probably remember this. He said, AI will not replace physicians, but physicians that do not use AI will be replaced. And so he definitely thinks there's a place for this, even through with all of these activities. So I just thought I would pass that along because that just kind of stuck in my brain after, I think it was the last risk adjustment forum where I heard that. Okay, time for another polling question, making sure that everybody's awake after lunch. And I promise you will know very soon why I'm asking this question. So, how many diagnosis codes are allowed on an electronic claim? So this is an X12837. A, there is no limit. The limit doesn't exist. If you remember that from Mean Girls. B, 12 professional, 12 institutional. C, 25 professional, 25 institutional. D, none of the above. And E, what is EDI? So we'll give you just a few minutes to respond to that, and then Bailey will pop the results up there on the screen. I know a lot of people might not know what an X12837 is, and that's okay. All right. So 18% said there is no limit. 57% said 12 professional, 12 institutional. 10%, 25 professional, 25 institutional, 12% said none of the above, 3% said what is EDI? So the correct answer is none of the above. Now, this is kind of a trick question because none of the above, it actually is, with your professional and institutional, you've got 12 professional, 25 institutional, right? But there really is no limit to what you can report to CMS. Although the actual X12837 claim has a limit to what can be reported, but there are ways that you can ensure that, say, a particular member or patient, they're very ill and they have 50 diagnosis codes that need to be reported for risk. There is a way to do that. So a little bit of a trick question, but all right, it's very good. And for those of you who said, what is EDI? That's okay. All right. So I want to talk now about the next step along our continuum, which is operational reporting. Now, this type of operational reporting, which is the non-CDI part of our discussion, because it really complements what you're doing with the actual CDI activities, will require you to have access to somebody with sound analytical skills, because they will leverage the data necessary to tell you how you measure up against your metrics and if your program needs tweaking. And these are a good place to start in setting your operational metrics, although there certainly are a lot more. I've seen a wide variety out there in the industry. Also consider your information distribution strategy for any reporting that you're giving. Will this reporting be accessed through some sort of a portal, or are you going to distribute it some other way? And how will you know if it's being accessed? You might want to consider paying regular visits to those who are not meeting metrics and engage them to develop a specific action plan. They may need help identifying a person, process, or technology to help them address their unique issues. So get ready to be creative. So we start with not coding to the highest specificity and excessive use of unspecified codes. And because you want to determine, is this a code set issue, meaning maybe the EMR, which is, the core claims, where the claim system and the EMR system is, doesn't have the most updated set of diagnosis codes, because they are updated 4 times a year. The big update happens in October for being effective at the beginning of the year, but there are updates that happen periodically during the year. So you want to make sure that those are not lagging, because you could experience problems when you submit those encounters to CMS with rejections for invalid diagnosis code. Not to mention, not coding to the highest specificity could be a knowledge issue, meaning whoever is doing the coding, whether it's the provider, or someone who is verifying, needs to know, oh, wow, could a more specific code work here? Because remember my example on a few slides ago with the acute systolic CHF versus CHF nonspecific. It really makes a difference with risk and quality. So you want to make sure that you know whether it's a system or process issue with the code sets, or is it a knowledge issue, because that determines how you're going to address it. And of course, you can easily run reporting that tells you, the providers and who are using these codes, because we certainly know what those unspecified codes are. Second thing you want to take a look at, and this has to do with the 1225 diagnosis codes, is there truncation of diagnosis codes happening? And by looking at the average number of diagnosis codes on claims, because there's a maximum diagnosis capture on an electronic claim, as we talked about. So you want to make sure that your EMR allows for at least that many, and that all captured are dropped to claims, because I have seen where there's submission deadlines, of course, for risk adjustment, no matter the market you're in, where a plan is like, why is our risk adjustment average score so low? What's going on? We're submitting encounters. Come to find out, for some reason, diags are not dropping to claims. And so that needs to be investigated. And you can easily see, for example, when you look at the average number of diagnoses for your whole provider base, and say you've got 10 providers that are consistently reporting only one diagnosis, and you do some probing, it's like, wow, these people when you, like, if you do a chart review, for example, and you see, wow, there's more than one diagnosis here, and to find out why that's occurring and then address that as your root cause. So it's very helpful to know, what your average number of diagnoses on claims is. And it also goes hand in hand with the average HCCs per member when you're looking at risk gaps, and per provider, so that you can look at undercoding rates. And that's what we talk a lot about on the risk adjustment side. But we talk less about looking at average number of diags on claims. Take a special look at your paper claims because they capture fewer diagnoses. And these days, most EDI percentages, most health plans are well above 90% EDI. So if you're less than that and you're accepting a lot of paper claims, this could be a problem for you, the truncation and the average number on claims, because the EDI allows many more than paper. Also, make sure super bills are updated, because it's easy, just to check off diagnoses that might not offer the specificity that's needed. And it also might not offer, making sure that all of the conditions that that member has are captured. And like I said, paper claims allow far fewer diagnoses and they're more prone to errors. All right. Next, we have high-risk diagnosis codes. And as I mentioned earlier, that's a top-of-mind issue these days, because the OIG are performing these special audits that are focusing on 7 to 10 high-risk HCCs that they are calling. And I included a link here for a toolkit that they have published. I'm sure a lot of you have probably seen this, but it's a really good tool that they are using for health plans and other entities to know exactly how they conducted the audit so that they can be replicated. Now, as an example, they're looking at things like acute MIs and CVAs in the office with no corresponding inpatient claim, cancers with no evidence of active treatment. So this would be active treatment versus history of, vascular claudication with no medication therapies, and et cetera, et cetera. So they specify in there what they're looking at and how to determine, what your risk is based on your population, so you can be ready when your audit comes. And like I said, they're looking at active versus historical conditions, suspected versus confirmed conditions. And then you can also write rules in your system if you want to be really sophisticated. A good analyst can do this to catch these and maybe give them to somebody for further review. Lots of creative things that you can do here with rules to make this a little bit easier, smarter, and not harder. Also, a lot of you are probably doing this. Most health plans do some sort of claims denial analysis. So this would be also in light of, remember, top of mind issue is prior auth, paying special attention to prior auth denials and making sure that your system configuration is set up to make sure that these flow smoothly through the system. Because I have seen on more than one occasion when I am out, talking to health plans and helping them align with industry best practices, where they have configuration issues between the prior auth system and the claims system that cause denials to happen when they shouldn't. So something to look at if this is a particular problem, or you're trying to get your strategy together for how you are going to address prior auth denials in light of the attention that it's being paid. Also, something that's frequently done in risk adjustment, conditions suspected. So this is pre-CDI versus conditions captured on claims. And we talked about this a little, somebody reviewing to make sure that the open gaps for risk and quality that were identified before that member came in were addressed and dropped to the claims. So doing that analysis to make sure that it's all buttoned up. And then here, queries. You see queries here again. Also wanting to monitor your query rate and the timeliness that they're being answered and their quality. And again, a whole webinar could be done on queries, but it's something that's really important to monitor. Some people are like, oh, we do queries. That's it. Well, you need to make sure that they, are timely, then that they're of good quality. And we'll talk about some strategies for querying here very shortly. All right. Now, speaking of queries, like I said, we have some special information about queries. We all know that queries should be clinically meaningful and cite evidence-based guidelines, because clinical relevance promotes higher trust and engagement. So basically, the more meaningful they are, the better chance that there's going to be that they are responded to in a timely manner, and that those providers that are receiving them, you'll have more buy-in with them. And so that's why I have that there as your first consideration. Now, your second, you'll want to narrow that gap between doctor speak and coder speak, and I think we all know what that is, by using tools that they are familiar with, such as medical textbooks, journals, and online resources, and not necessarily Coding Clinic. I mean, you can use Coding Clinic, but you need to use other tools that they are familiar with. Speak their, talk their talk. And I made a note here that the Association of Clinical Documentation Integrity Specialists, we call ECDIS, has a list of query templates that are available in their resources area. Now, you do have to have a membership, of course, to access these, but they are worth their weight in gold. And I provided kind of a little example of what the screen looks like here. So if you're wanting some resources on querying specifically, I would encourage you to check out their website because they have a lot of really great tools that you can use. And moving further on to the most right-hand side of our maturity model, we have financial reporting. And nothing gets people's attention quite like money. So along with your operational reporting, you want to have robust financial reporting so that you can know how your operational efficiency or lack thereof is translating into dollars, and how to communicate this meaningfully to providers. It also provides good information if you need people, you need technology, you need tools to help you. It provides that financial justification for getting them. Now, providers are a competitive lot, so showing how they compare to each other and their peers over time and how they're improving can be a good tactic for affecting change. It's also a good tactic for sustaining buy-in for your programs. Now, as I mentioned earlier, scheduling time to review these reports with providers face-to-face rather than just emailing them a bunch of reports is much better because they may or may not read those. I can tell you from personal experience, having worked in provider's office earlier in my career, that food helps when you show up, to review their reporting. And again, your provider or network relations department should be facilitating this, and there should be a formal program. And there are many tools available to provide this kind of reporting. So leverage those folks to help you, look at your data, find out what providers need visits based on, what we were talking about operationally and now financially. And with that information, go and talk to them, engage them, bring food. So, all right. Now we're coming back to education. And you probably remember in our maturity model, I actually had that as first. If you are newer and wondering, where do we start? Education, always a good place to start. So we have a few tools here. And I just wanted to point out in our industry, there's certainly no dearth of resources that help inform the development of effective programs. Most of them are also relatively inexpensive to join, and if you need justification for the expense of attending conferences like RISE, for example, that focus on CDI and other relevant topics, it is very easy for a good analyst to quantify the ROI that's related to operational and financial losses due to a poorly designed and executed CDI program. That's very easy to do. So, we have in-services and provider coding boot camps. Those are very effective, especially for newer providers. And this really isn't just for the new folks. It should be ongoing. Education is an ongoing endeavor. We have industry associations such as RISE and AHIP, that are really good sources of information, give great webinars, great conferences, have a number of experts that you can get in touch with if you have questions. So avail yourself of those, the tools that those organizations offer. CMS, HHS, and state Medicaid departments are also a wealth of information. And a lot of you who work in this space are probably very familiar with the various CMS communications that come out about a variety of things, but they are also a really good source of information when you are considering educational needs. Also, your professional organizations. Of course, you have the AAPC, American Association of Professional Coders. You have AHIMA. HFMA, and then what I mentioned earlier, the Association for Clinical Documentation Integrity Specialists. All of them are excellent in terms of the educational content and conferences that they put out there. So important to consider those as well. I also mentioned LinkedIn because, of course, a lot of us probably follow folks out there that are experts and have a lot to say, especially when big industry announcements are made, such as the recent release of the advance notice for Medicare Advantage and also that prior auth rule. And they're out there. They have a lot of good things and good information to say about those. And so, do a search, follow those folks, engage with them. A lot of them are always happy to answer questions, hop on the phone. I'm one of those folks, always glad to answer questions and hop on the phone and help out. Always happy to do that. And I wanted to say just a few words about, of the physician champion. And the importance of having a physician champion cannot be understated. They will be your biggest advocate in gaining clinician engagement and enablement with your program. Now, yes, operational and financial reporting will tell you about outcomes, but the champion can provide valuable input on what causes provider abrasion and challenges to having successful outcomes reflected in the reporting. So ultimately, you can't monitor what you don't measure. And your operational and financial metrics will tell you how well your educational program is working, because you will probably construct something that is a matrix of a lot of these different things. Now, the natural inclination is to focus on new clinicians, but the pace of change in the industry necessitates ongoing education for established clinicians. So you want to have one for new clinicians, one for established clinicians. In other words, education cannot be an afterthought or something that only happens in response to problems identified in the outcomes that you see in the reporting. Ongoing. Here, we will take one last look at our model. And so again, you see this as a continuum because it may be overwhelming to be, oh, where do I start? There's so much. Hopefully, I've given you some food for thought on where you might want to start, and what things you might want to be thinking about as you mature your operations. And so I'm hoping that this will make you feel a little less overwhelmed about developing and implementing a program. And certainly if you are a seasoned vet, to feel reassured that you're aligning with industry best practices. And so with that, I want to answer some questions. Let's pop over into the Q&A and see what we've got. Okay, so the first question I see here is, what types of SDOH data should be captured besides low-income subsidy, disability? Where can I find this list of social determinants of health data that will be included in the future? So social determinants of health are, there are 5 domains of social determinants of health. And these are things like education, homelessness, food insecurity, violence in the home, just all these things that affect our health. And it is actually estimated that our 80-ish% of our health outcomes are driven by social determinants of health as opposed to organic disease. So these are things that are very impactful that aren't necessarily, pathogens or fractures or things like that. So that's the type of data that you want to capture. And there are actually Z codes that are associated with these social determinants. So for coders and folks out there, these are a set of Z codes. There's a couple others that aren't, but mostly Z codes that capture things like homelessness, food insecurity, violence in the home, a whole wide range of things that are in the social environment. So there isn't, CMS has not yet released a list of how, what these codes map to in terms of an HCC or some other factor, but they will very soon. They are still working on that. But it's important before that happens to go ahead and make sure that whatever, EMRs, super bills, paper, whatever you're doing to capture in the chart includes a screening for these. So when that member comes in, asking them, if they're experiencing problems with homelessness, if they are experiencing problems getting food, if they are, experiencing problems with violence. And there are actually screening tools. One is called Prepare, Prapare. That's one of the ones that CMS mentions as being a good one to use for social determinants of health screening. There are others, but that's a good place to start in terms of, how you might want to conduct a screening, and then deciding who does that and making sure that that information in that screening somehow gets into the EMR or it's entered directly into the EMR. So I hope that that answers your question. I've done whole webinars on social determinants of health capture. And when I did my AAPC fellowship, I wrote a whole paper on the capture of SDOH data from a coding and auditing perspective. And I'm happy to share that with anybody that might want to see that. Okay. So relating to the too good to be forgotten slide, what are the suggested KPIs that should be measured to measure provider engagement? So we're going to pop back here and we'll take a look at where we started with operational reporting. Now, some people might be like, this isn't directly provider engagement. However, when you're doing that education of your providers in terms of, how well they're documenting, and you're finding when you want to look at some of the root causes of why there might be issues with documentation, you want to start here because you want to make sure that they are coding to the highest specificity, and if they're not, why that is, if claims don't, are having truncation issues with diagnosis codes, looking at high-risk diagnosis codes and how well those are being coded. So that's another way to take a look at it. Denial analysis. And then when you've done some of that operational reporting, and then we'll over here to our financial reporting that we talked about with our trending month over month, year over year comparison to peers. If you are doing some of this longitudinal monitoring of your providers, like say you determine that a provider has a truncation issue because something is happening in their EMR that's causing that. You go out there with your provider relations department and find out why that's happening. Perhaps they're having some technical issues they were not aware of that can be fixed. Perhaps it's, there's, something else going on. It gets fixed. And then if you're trending and tracking over time, you can see how effective that engagement was by now they're not truncating. You see they went from submitting 1 average diagnosis per claim, maybe to 5. So, and you can of course set your benchmarks based on your organization. So when you see that type of situation happening, or when you've engaged with them because they have a higher number of non-specific diagnosis codes, say it's the acute systolic CHF, because that's an important one for risk adjustment, and say you've gone out there, you've found, they're having some documentation challenges, maybe they need some education, that happens. And then when you run your reporting month over month or quarter over quarter, you see that their usage of those codes has gone down. So that's how you can truly measure whether the engagement is working. Are you seeing movement, positive trends in these, are they submitting better, more specific diagnosis codes? Are they submitting a higher average number on their claims? Are they, are they doing a good job of capturing what was identified as a gap before that member comes in, and then is that being dropped to a claim? So being sure that you follow up continuously, it's not just a one and done type reporting situation. So hopefully that answers your question. And it looks like we have here, we have one that says, as a payer, it's important for us to consider how we can assist healthcare providers in accurately reporting HCC, hierarchical condition category conditions, especially when they use different electronic medical record systems across their clinical network. This can be quite challenging for providers who may require additional resources or technical expertise to navigate and utilize these tools effectively. Therefore, it's crucial to explore potential solutions and strategies that can help simplify the process for providers while ensuring that HCC conditions are reported accurately and efficiently. Do you have any suggestions for payers that could help them in that regard? That's yes. All of that is excellent and true. And so related to looking at the different EMR systems across clinical networks, the ability to identify gaps before that member even walks through the door is really one of the most critical activities that needs to happen if you're leveraging the EMR systems. And so if providers need some additional resources or technical expertise to use these tools, it's really worth it to have your CDI specialist or your provider relations department provide that kind of education. You'll get to know those systems. If they've got some technical limitations, helping those providers explore what they might be able to do. And I actually got a question here that relates to this about a lot of our data issues are related to things like diagnosis code truncation and EMR related issues. What should I do to get those addressed? So in that case, hopefully there is a resource at your organization, if you are at a payer, who is in charge of vendor management for the EMR system, because it will be necessary to engage with them and follow their process for requesting these enhancements and development of new processes and enhancements to address these things. Now, this can take time. And it definitely takes patience. But remember, you are their customer, and there is revenue tied to being what is requested. Don't be afraid to tell them what is at stake and what your expectation is for delivery, because this will help them properly prioritize your request. And you might even want to consider contract language and SLAs with the vendor to address service delivery. So you want to, if they are using, these tools, you want to make sure that the tools are working for them and help them be able to identify what is not working and what they might be able to do to fix it. And so it's a collaborative effort. And like I said, avail yourself of your provider relations staff and others who can help facilitate that process. And it's well worth it. It's not good just to run these reports that I've been talking about for operations and financials, but not do anything to help address the root causes of why there are problems. Got to be able to engage with those providers, talk their talk, figure out what their pain points are, and what you can do to proactively address them. Now, I have a question. This is a coding question. To avoid risk, is it best not to report the acute stroke in the office since it most likely would not be confirmed without imaging? That's true. It's the same for acute MI. Not that it never happens in an office, but certainly it is very risky to report those things in the office, and because they do have to be confirmed with other testing. So and of course you want to be sure to discuss this internally with your coding departments, and to make sure that you are following coding guidelines. And of course we all know the coding guidelines are what governs these things, so you just want to make sure that everybody who is doing coding and the providers are very well versed in those guidelines, so that they know for things like acute stroke and acute MI and other problematic conditions, make sure they know, this is when it can be reported and this is when it can't. Can we get a copy of the presentation? Absolutely, you may. And Bailey's going to be facilitating that for us. Let's see. Do you offer physician CEUs for training? Any suggestions on how to implement this for a health plan? I think offering physician CEUs will help improve the number of providers that attend training. That is true, and that is definitely something to consider. As far as suggestions on how to implement this for a health plan, admittedly, I am not that familiar with the process for gaining CEUs for physicians, but I would imagine that anything's possible, and it certainly could be possible, because you are right. Incentivize them, for their time would be a great way to make sure that they're getting engaged, and I would think that that would be possible. So stay tuned on that. Okay. Somebody says, thank you for presenting this information. My pleasure. I'm interested in learning more info on social determinants of health. Is there a calendar of events you will be presenting? Have any podcasts? Or how is it possible to get in touch with you for mentorship? Reach out to me directly. I did do a podcast earlier in the year for the AAPC. They have a podcast called The Pulse. It is on Spotify and a variety of podcast platforms where I talk about SDOH. And it's a short podcast, maybe 20 minutes, but it's a really good overview of exactly what you're looking for. So check that out, anybody who's interested in that. I have done webinars for RISE in the past on SDOH, and those might be archived somewhere that you can look up. And a lot of other vendors have done them too. There's a lot of great content out there about social determinants of health. And yeah, we should. I have my marketing director on here. We might even want to resurrect our social determinants of health content if there's interest in that. Yeah, please reach out to us, because if there's enough interest, we can definitely do that.
Hey, Dawn, I think we have a couple on our YouTube channel, on the Centauri Health Solutions YouTube channel too,
Do we?
that you did Rise. The one you did with Justin.
Very good.
With from Arkansas Share.
Oh, yes, yes. Thank you, Gretchen. We did, yes, I've done a number of webinars with Justin Valines of the Arkansas Department of Health, and he is in charge of basically the HIE for the state. And of course, his focus is a lot on interoperability, but there's a lot of synergy with social determinants of health. So yeah, check those out, because those were fun webinars. Justin's really fun. So I encourage anybody to check those out that wants more information about that. But check out the Pulse podcast. Are there different approaches to engagement with non-incentivized versus incentivized providers? Yeah, I guess you could say yes. Because incentivized providers, of course, if they're being incentivized to perform better coding, you're going to see better results. But I think it begs the better question is, you might want to consider incentivizing your providers if you're just not getting anywhere with your program, because they do a better job if they tend to, if they are incentivized. Now, what that looks like, varies. Is it a financial incentive? Is it something else? Definitely something to consider as you are setting up your program, because it does make a difference. And we are a small health plan, and currently we rely heavily on retrospective chart review. What is the best way to start introducing prospective coding and engagement? And the answer here is education. Definitely, craft educational material and collateral that introduces this in terms of why it's important, and making sure that you have a good strategy mapped out for how you're going to do this. Because nothing's worse for a provider than being told, we're going to start doing this, tomorrow, and that you'll get a lot of resistance and a lot of abrasion. But if you when you're setting your strategy, make sure that you give plenty of time, for education, even plenty of time for maybe some mock auditing to happen, just so that they can get a feel. And especially if you're incentivizing providers in this regard, giving them some ramp up time is really helpful, so that when it's time for go live, they're ready to go. They understand what's expected of them, and and if they're incentivized, what types of incentives that they're going to get. So it's a very important to plan in this, can't plan for this. And education. And of course, there's a number of resources, like I said, that are available, to help you craft a program that is going to work for your providers. And of course, it also, along with education, is understanding your data and taking a look at some of the coding pain points and some of the things that I was talking about, so that you can be armed knowing where they might need some additional help as you're considering your strategy. So hopefully that helps. So education and taking a look at your data, understanding the story that it's telling you, so that you can craft something that is individual for your organization. And I think that is all we have. So anybody else that has questions definitely can reach out. You know, if you don't want to pop them into the chat, because I know we've got about 5 minutes left and we've got some final housekeeping that we might want to do here. But I want to thank everybody for joining me today. Hopefully this was helpful for you and you came away with some takeaways that will help you with your clinical documentation and non-clinical documentation improvement initiatives. I certainly invite you to reach out to me if there's anything that I can help you with, any questions I can answer. And also, don't forget that we have Rise National next month and Centauri will be there. We'll be there with our subsidiary companies, Secure Health Solutions, Secure Exchange Solutions will be there to answer questions, interact with folks. We would love to meet with you and say hi. So if you're coming to Rise National, please stop by. And with that, I'm going to hand it back over to Bailey to wrap us up. Bailey?
Awesome. Thank you so much, Todd. And on behalf of Rise and everyone at Centauri, we just want to thank everyone so much for attending today's webinar. As mentioned, you will have access to the presentation as well as the recording. You'll be receiving an email from Rise tomorrow with this, and it'll be available online as well. So with that, we have come to